Thank you, Jens. Thank you. Thanks to all the co-chairs for inviting me. It's a great honor and pleasure. Can you see my screen?
Yes, nice and blue.
Excellent. Yeah. Well, thanks a lot. Thanks to the Seattle Spine Foundation. So it's really a pleasure for me to present here some of our thoughts of our results regarding osteoporotic fractures. As Jens has pointed out, dealing with this topic now from a scientific point of view over more than 10 years. I have the honor to chair the Osteoporotic Fracture Working Group of the German Orthopedic and Trauma Society. I'm the chair of this society. I'm not chair of the German Spine Society yet. It will come in the nearby future, but currently I'm chairing the spine section of the, as I said, German Society for Orthopedics and Trauma. So, well, osteoporotic fractures, different topic, of course. We're moving from really severely injured patient with spinal cord injury, etc., to the elderlies. And why is this important? These are my disclosures, not really related to the talk. Why is it important? Because the number and percentage of the global population age over 65 is steadily increasing. And a matter of fact, what we see here in our daily practice is that more and more patients, elderly patients with fracture come, while the number of patients, younger patients with injured spine are decreasing. And in the first talk this morning from John, we heard that this is not only in Germany like this, it's in the US the same. So the elderlies are coming, and the elderly patients do have more and more vertebral fractures. And it's like a tsunami coming to us. So when we see here the estimated numbers of osteoporotic fractures in the future, we will see that they double or even triple sometimes. So we have to deal with this patient because we can't just say, well, it's an osteoporotic fracture, they will heal on their own. We don't have to do anything about it. So just give them a brace or whatever, and they're doing fine. It's not like this, because we see that these fractures cost a fortune, $1 billion annually in the US. And even though we pay this high amount of money, we still have 40% of patients with inadequate pain relief 12 months after the injury. So it is an issue. And it's not only the frail patients coming, it's sometimes really patients who are 75 but really active, and they want to go back to their daily activities, sports, whatever, leisure activities very soon. So they demand treatment. Here are some facts about the osteoporotic fractures. When we look at them, we see that the most common types are either benign. They're either A1 or A3 fractures according to the Eurospine classification, so end plate deformities or incomplete burst type injuries. So, and B and C type injuries are rather uncommon, as well as neurological deficits are rare. They just account for 3% of the injured patients. But progressive kyphosis is a problem because it is quite common, roughly 40%, and especially if the T-score is really low. So if you see a T-score less than -3, you may have the situation that the patient will come back if you treat them just conservatively. Well, osteoporotic fractures differ from other fractures. We have looked at more than 750 fracture types, and what we found is that the fracture morphology differs from the healthy bone fractures. They look differently. The morphology can change over time, sometimes leading to highly unstable situations. And by just looking at the images, you can distinguish whether a patient suffered from a trauma or not, because it looks the same. The only thing you can say is or see is that typically a patient with a trauma has a high degree of fracture, but the morphology is pretty much the same. And as I said, a benign fracture in the beginning can end up with a severely unstable fracture at the end. For the patients, the most important clinical parameters are pain and the mobilization. So they want to get out of the bed, they want to become mobile again, and they have to get rid of the pain. However, from our perspective, surgeons' perspective, the comorbidities are important because many of them have them. Some are frail, some suffer from sarcopenia, other comorbidities, and these comorbidities may change our treatment decisions. We looked for specific risk factors for conservative treatment, because conservative treatment is definitely, well, the thing we do for the vast majority of our patients. But especially if the bone mineral density's T-score is less than -3, if they are frail, and if they have certain fractured morphologies, they are prone or they are at risk for failed conservative treatment. And especially if they have burst type injuries, initial gross height loss, intervertebral clefts, decompensated sagittal balance, as well as some specific MRI fracture types. We know that these fractures are at risk for failed conservative treatment. First of all, when we talk about the fractures, we should talk about the common thing, the classification, because the current classification, whether AO or TILIX or whatever, they are not created for osteoporotic fractures. And as I said before, the morphology differs from healthy bones. So here, in a combined effort of the German Orthopedics and Trauma Society, together with the AO, Spinal Knowledge from Trauma, we created a new classification for osteoporotic fractures, and we call them OF, classification for osteoporotic fractures. And I will just lead you quickly to this. It has just 5 subgroups. It's easy to remember. It's OF1 means that you have no deformation visible on the plain X-rays, or even sometimes not on the CT scan. So it's just the bony edema if you perform an MRI scan. So sometimes you just see the fractures accidentally. It's a bone bruise in the vertebral body. OF2 means that you have a deformation of one end plate, and we don't say fracture because typically it's more deformation we see in those patients. And OF3 is a deformation of one end plate with distinct posterior wall involvement. So this would be like an incomplete burst type injury. The OF4 are a deformation of both end plates with or without a posterior wall involvement. That means that it's either a pincer type injury, a complete burst, or a flatten or fishbone injury. And finally, we have the rare OF5, which are injuries with either anterior or posterior tension failure, which would reflect the B and C type injuries according to the Aerospine classification. So here it looks like there are some illustrations showing you that the OF1 is just a bony edema. OF2 means end plate deformity. It could be the upper or the lower end plate. OF3, deformation of one end plate with distinct posterior wall. And the O4 is then either a complete burst, fishbone, or pincer type. O5 means that there's mostly the posterior PLC is affected, and therefore then it becomes highly unstable. So how often are these fractures? So typically we see OF2, OF3, and OF4. Really rare are the OF1, and rare as well are the OF5. But as I said, an OF2 can become an OF5 over time because of the low quality of the bone. So how can we treat the patients? Though, of course, conservatively, then the kyphoplasty or vertebroplasty is definitely a treatment which you can think about. Well, but posterior percutaneous stabilization is another option. I will show you when we use it and why we use it. And finally, in rather rare cases, you will need even open posterior or posterior anterior stabilization techniques. So, but before we decide what kind of surgical treatment we use, we have to say, well, what kind of treatment do we need, a conservative or a surgical treatment? So here, typically all of you have your own algorithms, you have your treatment ideas, how to deal and how to judge the fractures. And here we propose a score where we think it's helpful in daily practice to decide whether patients need surgery or not. So the score has parameters. Morphology plays definitely a role according to the OF, so you grade them and you double the points. The severity of osteoporosis, if the T-score is less than -3, for instance, as we just pointed out before. If you treat them conservatively and over the time you see a progression of the kyphosis, then you may consider surgery, so you can give points, etc. Pain, as I said before, the VAS is over 5, that may trigger surgery. Neurological symptoms definitely can trigger surgery if their patients have one. Mobilization is important, and finally the health status. So here you can grade all these parameters and give points or take off points, and finally we'll come up with a sum, which is either then higher than 6, then it would mean surgical treatment, or it's less than 6, then you would go for conservative treatment. How does it work in daily practice? Here's an example. It's a 70-year-old female with an severe osteoporosis. T-score was -3. And the fracture at L2, you can see in the image in the upper vertebral body here, it's a deformation of one end plate with a posterior wall affection. So that means it's an OF3. Patient was mobile, VAS was 4. And of course, you would consider conservative treatment here. And that actually sells you the score as well. So for the morphology, you get 6 points. The low T-score, give another point, but you can take off a point because the patient is not in that much pain, as well as the patient is mobile. So at the end, you end up with 5 points, which means conservative treatment. So we did. But, and this can sometimes happen, especially if you have this low T-score, after a few weeks, or then patients come back and complain about a lot of pain. And when you make an X-ray again, you see, oh, wow, now we have a kyphosis and the morphology changes. Now we have an over 4, both end plates are affected. So again, we take our score, and now we see that for the morphology, there gets 2 more points, kyphosis progression, another point, severe pain, another point, and finally we sum up with 10 points, and that means surgical therapy. And in that case, because the conservative treatment failed in our eyes, we treated the patient conservatively with a kyphoplasty and with a long-standing good result. Well, kyphoplasty is safe and effective. We know this. Even though in 2009, 2 studies were published from Kalmus and Buchbinder questioning the vertebroplasty technique, but the methodology of these studies were not really good. So very recent later, other studies, prospective randomized studies, were published showing that kyphoplasty is effective as well as vertebroplasty. So we still think that's a valuable technique for patients for pain treatment, as a matter of fact. However, it does not work in all cases. Here's an example. A patient has a T12 fracture. There's a standing X-ray on the left, some kyphosis, a kind of over 4, probably over 4 fracture, maybe over 3. Not really sure whether the lower end plate is affected too. But anyway, the patient was treated with kyphoplasty. You see it in the middle. So there was another fracture that treated too with kyphoplasty, but this is a supine X-ray. A few days later, patient developed a kyphosis, pain, and an adjacent fracture. So the colleagues made a kyphoplasty again in the adjacent vertebral body, but the problem was that the instability did not go away. So this is a standing X-ray on the right. You see the marked kyphosis, and on this CT scan, which is made supine, you can see that it opens up, so it's an instability. So kyphoplasty is effective in many cases, but we don't think in all. So sometimes we need a little bit more. Here's an example, 60-year-old female, very active lady, osteoporosis minus T-score -3, an over 3 fracture, only 1 end plate was affected, the lower end plate was fine, and the VAS was 7, and she was bedridden due to the pain. So we use our score. Again, so you get 6 points for the morphology, another point for the T-score, because of the pain, another point, and the mobilization, another point. So after all, 9 points, but we took off 1 point because she had an active anticoagulation, and therefore we ended up with 8 points, which means surgical therapy. However, it's not an emergency. We can always wait and start and try with a conservative treatment. So we did. 1 week later, the anticoagulation was gone, but she was still in pain. Situation was the same. She could not really get out of the bed. So we decided for surgical therapy. And here, of course, kyphoplasty would have been an option, but we think, especially to achieve a lot of stability and restore the physiological alignment, percutaneous stabilization with PMMA augmentation of the screws is a very meaningful technique, very easy, minimal invasive, percutaneously done. And in that cases, we typically use a kyphoplasty of the fractured vertebral body. So we call this a hybrid technique. So where we use percutaneous screws and the kyphoplasty. And it has become a kind of workhorse in our environment. So hybrid constructs, those like I just showed, are effective. Unfortunately, we don't have so many prospective studies, and there are no comparative studies, but what we know from the retrospective and the few prospective studies is that it works quite well. So it's a relatively safe technique. The complication rate is rather low, with roughly 5%. We see some adjacent fractures over time, yes, of course, but typically it can be done very easily. Patient can get out of the bed, and it's at least as we know, for 1 or 2 year follow-up, it's a safe technique. So kyphoplasty or vertebroplasty, as well as the short percutaneous hybrid constructs, are, I would say, the working horses and the ones we do the most. The kyphoplasty is good for OF2 or 3, sometimes OF4 fractures, but especially if you have a kyphosis, especially if you have a vacuum phenomena, etc., you should probably think about a short percutaneous stabilization, so for the OF3 and especially for the OF4 fractures. In some cases, however, you need a longer construct, either mostly percutaneous, sometimes open, for the O4, O5, or for multiple fractures. Then typically you can either, it's advisable to augment the screws, not all of them. It's typically enough to augment the uppermost and the lowermost screw pairs, but you don't have to augment all of the screws, but it's definitely advisable to augment some of the screws in order to reduce cutout of the screws and implant failure. So here's an example, 70-year-old female, very low T-score, almost -5. She had a T11 fracture, you can see in the upper right CT scan image, both end plates were affected, so it's an O4. She had another OF2 fracture at T12, it's not so important. She got an OF score of 11. So at the end, we decided for surgical therapy. And here we would think that in the thoracolumbar junction, with this marked kyphosis, we decided for a longer construct, so 2 levels above, 2 levels below, percutaneous, PMM augmented, and with the kyphoplasty of the affected vertebral body. This works quite well. However, the longer you go, the more you do, the higher the likelihood that the patient, will get any adjacent fractures, or maybe that the implant fails. So here it's important to look that the sagittal balance is at least not decompensated. So that means that the C-plumb line, for instance, is not anterior to the hips, to the hip center. So because if you don't achieve this with your technique, or if the patient has a severe global disbalance beforehand, your construct will probably fail. So in very, very rare cases, anterior posterior constructs are necessary, or even osteotomies, in order to achieve this global sagittal balance again. And it's mostly in severe O4 or with 4 fractures with kyphosis, or in unstable O5 fractures. Here's an example, 80-year-old female, otherwise healthy, although she was 81-year-old, T-score -4, fractures T11, T12 due to a fall 3 months ago. She came with this OF5 fracture, so it was the posterior elements were distracted, and she got 12 points, so clear indication for surgery because she was in pain. She was mobile, but she was really in pain because of a mechanical pain she had due to instability. And if you look here on the right image, you see the marked kyphosis there, and we see the CT scan, which is turned around, but you can see here that the CT scan, she opens up, there are intervertebral clefts. So it's an instability. Whenever she was standing up, she kyphosed. And when she was lying down, she opened up. So this instability caused the pain. And here it's, of course, a problem. You can't put anything like a kyphoplasty here and there. And if you bridge these 2 levels from posterior in this bad bone, in this weak bone, it probably fails. So here, in this case, you need more. You need a posterior and anterior reconstruction. And look, this looks like a gross surgery, but indeed, it's all done minimal invasive. Posterior percutaneously, and anterior, the 2-level corpectomy. This is the technique I use for all fractures. I, ever since 15 years, did not do any open big thoracolumbar frenotomy for fractures. I do this for tumors and deformity, but here for fractures, we do is typically minimal invasive. It's a 6-7 centimeter incision, where we perform the corpectomy so the patients can get up more or less the same day. So, or at least, let's say the next day. So this is done in a minimal invasive way, and I followed this patient up for 2 years. She was doing fine. However, she had developed an adjacent fracture at T7, but we did not have to treat them because she was fine. So in some rare cases, even this minimal invasive, but still invasive surgery is necessary to obtain a good result. But it's possible today with the techniques we have. So I think especially in the elderlies, minimal invasive techniques are the standard to treat them, because every open surgery, is a risk for the patient that it increase the risk of any complications. So in conclusion, the osteoporosis and the osteoporotic fractures are an increasing number. We have to deal with them every day in our clinical practice. So, and it's very difficult because we don't know exactly what to do. And we don't have so many good studies with long-term outcomes. We don't have prospective randomized studies yet. So we're still in the beginning, but what we know that is that the classification, the score, and treatment recommendations we have, which are based on the current knowledge we have and on expert opinions. But we know at least that they work quite well. And we followed up our patient. We did some prospective multi-center studies here in Germany, and the outcome is not bad, as a matter of fact, even though we are a little bit aggressive in terms of surgery. Kyphoplasty and hybrid stabilizations are our workhorses. They work in the majority of cases if we operate. However, comorbidities, especially adjacent fractures, and sometimes implant failures, are still challenging for us. So we need to investigate this further to avoid this in the future. And of course, never forget an adequate medication for the osteoporosis, because whatever we do, if we don't treat their underlying osteoporosis, the patient will come back with the next fracture. So thank you very much. This is a kind of summary of all the literature we published to this. It has been the score, as the classification has been published in Global Spine Surgery already in 2018. We have a video about this from the AO with regard to the classification. We have an app and website. You can check this if you're interested in, and I'm looking forward for your comments and questions. And thanks again for inviting me and talking about osteoporotic fractures, my favorite topic. Thanks a lot.
Great job, Klaus. We're applauding you. And in the chat room, there's a couple of questions also. So your passion really has been dramatic for this. So a couple of questions. First of all, from my end, then I'm going to go into some of the chat room questions. From my end, is there a subcategorization for these so-called avascular necrosis or Camel's disease patients where there's a large air gap in the vertebra? How do they fit into your system, and should we maybe put those into a separate aggressive treatment strategy?
So typically, good question, actually. We think that this Camel's disease, this vascular necrosis, is something which occurs after a certain time of conservative treatment, and this can develop in some patients. We do not know exactly which patients are prone to this, but it happens, and it typically is subgrouped with the over4. So mostly they look like over4 type injuries, sometimes even at over5 if the posterior or the PLC fails over time, but we subgroup them in the over4. So over4 necessarily alone doesn't mean to operate. But if you have something like this, you have this Camel's disease kind of pseudarthrosis, then you should probably consider the surgery. And then another aspect is that then kyphoplasty does not work so well, at least in my hands.
Great. So then a technical question by our good friend, Matthew Goodwin. Can you sneak a fenestrated screw into the fractured vertebra and use the fenestrated cannulation area to fill up the vertebral fracture?
Excellent. Yes, you can do this. This is an alternative to the kyphoplasty. We don't have so many good data, so that's why I didn't present it yet. But it's true. At least what I can say from my own experience is that works quite well. So in some cases, we put the index screw, we cement them, and therefore we enhance the construct, the stability of the construct. Yes, it's a good technique.
And Matthew Goodwin has one more great question there, and that is when you use one of those powerful metal cages, and we'll see it in the lab again next, John Herbert's going to show how those cages look in vivo. He's going to complete a corpectomy there right now. Do you fill the vertebral bodies above and below with cement? How do you make sure that those cages don't immediately intercept in those osteoporotic adjacent vertebrae?
Yeah, very important point and very valuable question, because this can happen, of course. So the lower vertebral body is not a problem, because if you cement it, you always have, there's the screws next to the upper end plate, and with the cement, you have a good foundation. The problem is sometimes the upper vertebral body. So if you cement them, sometimes the cement does not go to the lower end plate. So what I do here is intraoperatively, I put a cannula from the side, so from lateral into the vertebral body, and put 1 or 2 cc cement in. So I cement the lower part of the upper vertebral body, and I use always the biggest end plate of the cages. So the ones who go over the rim, so over the annulus. So I can subsidence does not occur so often. So with this technique, with the cementation, using the cement as well as with the big end plates, you can mostly avoid, in the majority of cases, avoid the subsidence.
So thank you, Matthew, for your great questions. Khalid Al-Madni has another question, and that is a great point. So your patient had wedging proximal. I'm not happy to see that this happens to you. Also, I just came from a meeting in Las Vegas last weekend, but we had literally a meeting of the minds, and everybody has the same problem. So is it sometimes better to put hooks on the top or cables on the top to try to prevent that from happening?
It doesn't prevent it. So that's the short answer. So I mean, it doesn't prevent it. This is an unsolved problem yet. And even you can use different techniques. You can cement the upper. So let's say in short construct, the shorter the construct, the lower the risk is of this adjacent problem. The longer the construct gets, the higher the risk, because you stiffen a lot of long distance of the spine. And then there are certain options you can use. You can cement, you can make a cementation, so a vertebroplasty or kyphoplasty of the adjacent vertebral body. You can use hooks, you can use wires, you can use whatever, but it doesn't really help. So currently we don't know what is the best technique. What we know is that the longer the construct gets, you more have to think like a deformity surgeon, and you have to avoid, that you stop in the apex of a kyphosis, that you have to look at the global balance. So I think this is more important than using hooks, etc. So if ever possible, stay as short as possible, because this avoids typically the adjacent problem.
I know you couldn't be there, but last night we had a case presentation of about 12 cases, and Rod actually showed a case just like yours with cementing above and below and a short segment fixation, a highly compromised vertebra, has gotten away with it over 6 months, so staying short. My partner Amir has some questions.
Thank you for the great talk. I know one of the things that I speak with my patients about is although very uncommon, the risk of cement extravasation. We hear about these disaster complications, but it seems like it's very uncommon. Sometimes we do see a little bit of cement in the canal. Most of those are asymptomatic. Have you seen any of these complications come up in your practice?
Of course, you always see complications if you work and if you operate. Yes, but there's some action points to avoid them. So first of all, as I said, it's typically enough if you cement the uppermost and lowermost screws. Second, think of the cement and wait for the cement, if it's really, low viscosity, so a high viscosity, so that you avoid it. Second, what you can do is that, especially for the if you do vertebral or kyphoplasty, that you use saline. You clean out the vertebral body before. So if you have a bipedicular access, you can put 10 cc saline and clean it out. You can higher the PEEP ventilation, so you can increase the PEEP. The anesthesiologist can do this, so you can avoid. So there are certain techniques, but I think the most important one is use not more than 1.5 cc per screw. Wait for the cement to be really tough, so really, really sticky before you inject it, and cement as much as you have to, but not too much. Because what I see is mostly that we always want to bring more cement in because they think more cement is better. So I think less cement is better.
Great point.
Once again, regarding the spine, I'm not so afraid of cement in the spinal canal, because I think that happens not that often, But what I'm more afraid of if you have an emboli and you have the cement goes through the cava vein upwards. So this is I've seen unfortunately death, so due to this. So this is the more problem I see, rather than that it goes back to the spinal canal. This you can typically avoid.
One final question, and that is building up a systematic program. Our American Orthopedic Association, AOA, has spent a lot of money on the so-called Own the Bone program. And honestly, on an everyday basis, we still don't see a big benefit. There seems to be no warning system in terms of osteoporotic extremity fractures, hip fractures, to kind of take a more systematic skeletal approach towards these vulnerable patients. do the German-speaking countries have some systematic programs that have an early warning system and a prevention system for osteoporotic fractures, so that they get a more advanced pharmacologic treatment, nutritional treatment, preventative measures, etc.?
Yes, we do have structured treatment protocols for osteoporosis in general. We unfortunately do have this we don't have this for the osteoporotic fractures. We have osteoporotic fracture liaison programs, but they are only some cities are available, unfortunately. No, they are not rolled out throughout Germany. So, but what people are, or doctors are aware, general practitioners are aware of this problem. The issue is that we typically start with bisphosphonates, and the general practitioner starts with bisphosphonates in these patients, but they are a little bit reluctant if the patients under bisphosphonates get another fracture, and then they are reluctant to give the next step, like romosozumab or like teriparatide. So they are a little bit reluctant to give this because they're still expensive. And we see in my daily practice, I see the problem that I see patients having 5, 6, 7 fractures within a few months, and then it's difficult to discuss with the general practitioner who take care afterwards that they prescribe sufficient drugs. So it's not really, no, we don't have a good, I would say it's not bad, but it's not really good what we offer here to our patients. It's room for improvement.
And we have a significant problem. We have one of the most overbooked specialties are mineral metabolism specialists who do osteoporosis management, because our primary care physicians usually don't want to do it. It's for them too complicated, and for us also. One more technical point. So Drs. Goodwin and Mitchell all want to shout out to the cement thing. Dr. Goodwin says 0.5 cc's per screw might be enough. And clearly overdoing it, like what you said, is a danger. So we want to really summarize that. So can you summarize the volume of the cement one more time so that everybody is totally clear? How little is enough, and what would you recommend?
So on average, we recommend not to give more than 1.5 cc per screw. I'm not aware of literature telling that. So there's no clinical literature regarding this. We have biomechanical studies. And I would say you don't have to cement the entire body. You need that cement is somewhere around the screws. If you see it after 1 cc, you can stop. I'm not sure whether 0.5 is enough. But definitely 1.5 is the maximum you should apply. I mean, it depends a little bit whether you are in the thoracic spine or the lumbar spine, because the bones are, the vertebral bodies are bigger or smaller. So, but the issue is more that, you have the syringe, there's 1 cc left, and you say, okay, I can apply this, why not? And this is sometimes too much. This final shot is too much, and then you see that the cement goes off the vertebral body, and you say, why did I do this? So once again, I don't think there's any clear consensus about it, but our treatment recommendation we just recently published, we said don't go above 1.5 cc. I think that's a kind of safe thing if you stay with this.
Very helpful, very pragmatic. Thank you so much for joining us in your late hour from Germany. It's 9:30 there at night. We'll want to switch to our co-chair, Dr. Rick.